Well, good evening again, everyone. Welcome back to our exam pro webinar series for the 2021 ABOG oral board exams. I'm your host for tonight, Rob Pegues. This is Sunday, so we'll be doing case list review. And I think 4 of our candidates are already up and ready, and I hope a few more to join us very shortly. So we'll get going right away. I think everybody's actually good on audio, so I'll just move through all that very quickly. And let's get to our case lists here. So I've got right there. Thanks. Let's see. We will be, again, happy to talk about anything that you would like to for your case list. We can discuss problem cases. We can do a just random mock oral. As we've been doing at our course this past week, we also can make up just other topics and talk about hypotheticals and things like that as well. Thank you, Ashley and Maria. We will get to you right away. Ashley, hi, can you hear us okay?
Yes.
Ashley.
Hi, how are you?
Thanks for joining us again. All right, have your case list right up here. Anything particular you'd like to look at tonight? Pardon me? I'm starting to lose you there. Can you hear us okay?
Okay, hold on. Yes, let me switch.
Oh,
hold on.
We're good. Oh, you're good. Whatever you're doing, you're good right now. You're doing good.
Okay, okay. All righty. Well, then I will stay right here.
Okay, great. I'm sorry, what? So what did you say before? Sorry.
So anything is fine.
Oh, anything. Okay, let's see. We'll go maybe OB to start. Let's see. We'll just pull something on the OB case list here. Let's see. Great. Can we take case number 20? I'm just picking at random.
Sure.
This is a 32-year-old, gravid 2, pair 1, 40 weeks, factor 5 leiden heterozygous, strong family history of VTE. And looks like you had actually a very nice outcome in this case. So if your patient presents on a first OB visit and you get that history from her, that she has a strong family history of VTE, and say, I'm sure family members were tested, and at least one of them had factor 5 leiden, so she got tested herself, and she is a leiden carrier. Can you tell me, for fleshing out your history, what would you consider to be additional important information that you don't want to know about her?
So for her, besides, we happen to know her factor status, which we may not always.
That's true.
And besides knowing that her mother, her aunt, her grandmother had all had VTEs in the past.
Wow.
Her sister actually during pregnancy and or delivery, if I recall correctly. I also want to know her personal history of DVT, because that will also change how we manage her as well.
Good, great. So if she discloses a previous history of VTE, how exactly will that affect how you'll manage her during her pregnancy?
So if the patient has had a previous history of DVT, then we're going to put her on therapeutic anticoagulation during the pregnancy.
Okay. What would you normally pick for your therapeutic anticoagulation?
Normally we do Lovenox.
Yeah, sure. For a patient who's had a previous DVT, how would you dose your Lovenox, and what would your plan for pregnancy be?
So for her, therapeutic Lovenox is going to be 40 milligrams BID up until 36 weeks, and then we would transition her to heparin.
Good, great. If she disclosed that her VTE event was a pulmonary embolism, would you be doing anything any differently?
Well, let's see. Besides therapeutically anticoagulating her and having her, working closely in conjunction with heme-onc, I don't think that I would unless she was symptomatic.
Sure. No, I think my question was, would you structure your therapeutic anticoagulation any differently?
I'm not sure that I would. I would have to look that up.
Okay, that's fine. Moving back then, if she has a VTE history, you'll anticoagulate her therapeutically. If she is a factor 5 leiden carrier, does she have to be anticoagulated during her pregnancy?
She does not. There's an option to either offer prophylactic anticoagulation or to manage her expectantly.
Good. So knowing her factor 5 leiden carrier status here, is there any other information that you would want or maybe would consider getting on her to help you determine sort of, if you are on the fence, how to manage her during pregnancy?
I'm sure there are other things, but obviously a pregnancy history. She is a multipara? So did she have preeclampsia? Did she have diabetes? Is she obese? Does she have other risk factors for preeclampsia in general? Is what I'm thinking of. Does she need to be on a baby aspirin?
Okay. Does her particular family history suggest any other testing you might want to get for her?
Well, this patient had already had a full workup as far as, if you're looking at the inherited thrombophilias, as well as, acquired, you're not really looking at family history as much. But if she hadn't already had that workup and had just presented with a strong family history of VTE, then definitely I would be sending, talking about working with Heme Onc and getting that workup done for her.
Good. What other things would you want to test her for? Or apparently what other things was she tested for?
Sure. So with a history of, with a history or a diagnosis of factor V leiden or factor V leiden in the family, you always want to look at protein C and S deficiencies as well, because if those go hand in hand, that does increase her risk of VTE.
Sure. Anything aside from protein C and protein S you would want to check out with her?
Sure. So the standard panel would involve antithrombin 3. You would also look at one more that I'm missing that I can't think of that I'll have to go back to.
Okay. Would you consider antiphospholipid antibody testing for her?
I thought of it. I'm sorry to interrupt you. It was prothrombin. I knew I was going to. Prothrombin 2010A.
Yeah, basically. That's fine. Yeah. Yeah, so we've got leiden, the prothrombin G mutation. Then there's protein C and protein S. You mentioned antithrombin 3, one of the super high risk ones. Antiphospholipid along in there also. Good. It's good to know the list there. So as an average American woman who is pregnant, if she asks you if she didn't have all the stuff, what would be her baseline risk of developing a blood clot or a VTE event during pregnancy?
I would say it'd be low, but obviously not as low as a non-pregnant woman not taking OCPs and just a non-pregnant woman in general. So I would want to say it's about 5% or less.
Sure, it should be less than that. Yeah, just for an average American woman, do you happen to know the number for an average American woman who, with no family history, not taking OCPs, otherwise healthy, and not pregnant?
Yeah, it has to be around like 2% or something like that, like 1 or 2%.
Well, you mean lifetime risk?
I don't know. I guess I don't know.
Standard, this might be good to know if they ask you. Standards would be for risk per year of developing a VTE event, just being an American woman of reproductive age, about 2 to 3 per 10,000 per year. Pretty cool number. OCPs about 5 per 10,000 per year, so it roughly doubles, but it's 4 to 5 per 10,000 per year. Pregnancy 100 to 200 per 10,000 per year. So now we're talking in the range of like 1%, 2%, 1 to 2% during pregnancy. Actually, is what that translates out to. Put it now. Factor V leiden you have here a heterozygous. That's like 3 to 8 times, I think. If you're homozygous, it would actually be 30 to 80 times whatever risk you had, and then you add that to pregnancy, you get into some real numbers there. Yes, but I would know maybe just the baseline risk. I think in OB it's good to know the basic risk for a pregnant woman. It's theoretically it's 100 to 200 per year of a VTE for someone who is pregnant during that year. Let's see. Good. All right, we got a lot done there. Ashley, anything you'd like to talk about this case? I thought we'd just sort of run through that aspect because I bet we haven't done it so far this year.
So one of the things in reviewing this case that had been brought up before I submitted it was that this patient she delivered at 40 weeks, 3 days, or came in for induction at 40 weeks, 3 days. I had wanted to induce this patient at 39 weeks, but she was like, no, I don't do that. I'm not going to do it. I'll deliver before that. And so finally, after seeing her quite frequently, I can't remember the frequency I did get her to come around and induce her, and it was fine. But are there any concerns with that, or is it just, if they ask, that's what I'll say what I just said, and then we move on.
I agree. I think it's nice for these people to deliver at 39 to 40 weeks and not to prolong the pregnancy. In general, you're sort of at the mercy of her particular wishes there, and I'm sure you counseled her appropriately. And you offered it to her, she declined. You continued to observe her, and she delivered it at a reasonable gestational age. So I think we're good.
Okay. All right.
All right. Nice, Ashley. That was a very useful topic to do. Thank you very much for doing that. Let's move along to I think Dr. Jones for just a minute. Go back over here. Get Ebony up for a moment. Oh, I'm sorry. I'd say actually, Maria. I have to do Maria. Maria was up next, and then Ebony. Sorry, Maria. There you are. Hi, Maria. Can you hear us? Okay.
Yes, you can hear me.
Hey, thank you. Ebony, I'll be with you in just a minute. Thanks. All right, got your case list right up here. Anything you'd like to talk about in particular, just as far as stuff you've been looking at maybe this week?
OB again, if that's okay.
OB sounds good.
Well, yeah, no case in particular. Just anything here.
Okay, let's see. We'll go down to the bottom of your list and we'll work our way up maybe. Let's see. Let's see. Sure, can we do multifetal pregnancy? Just because it's here.
Okie doke.
Okay, so 23-year-old first pregnancy, let's see, delivered at 33 weeks, late to prenatal care. Let's say that you had the opportunity to take care of this patient from her very first visit, and maybe she came in at 6 to 7 weeks for pregnancy confirmation. With your first obstetrical visit, do you usually obtain ultrasounds for pregnancy confirmation around that time?
Yes.
Good. If you did so, just her being just a healthy primogravid woman coming in for a first visit, maybe about 7 weeks pregnant, what particular information do you want to have from that initial ultrasound report? What are the important things that you would be looking for?
So you would be looking obviously for where the pregnancy is located, if it's intrauterine or elsewhere. With her having the twin pregnancy, you'd want to determine chorionicity.
Can you determine chorionicity at 7 weeks?
I think so, yes.
A little too early, but going back to this, what I'm assuming is she came in 7 weeks pregnant. You didn't know how many babies she had in there just yet. So the question we're starting with is on just a basic early prenatal visit at 7 weeks. What is the important information we want to get from that early ultrasound? First of all, you're right. Is the pregnancy intrauterine or not? That's the first very important thing. What else would you list as important on this very early OB ultrasound?
Well, I mean, I guess I would assume that you could see the embryo or embryos, and
yes,
possibly after 6 weeks, fetal cardiac activity or flickering.
Got it. So first one is the pregnancy in the uterus. Second is the pregnancy viable, or can we tell that yet? This is exactly what we need to tell the examiners. It seems just so obvious and so elementary and pedantic, but this is actually exactly what they need to hear from us. So those are two things so far. Anything else we'd want to know? I think there are 4 things we'd like to hit, and they're all very basic, and you've already alluded to the third one, I think.
I guess any sort of dating that you can get from...
Exactly, yeah, we'd like to have a gestational age to compare to our menstrual dating, right? So far, is the pregnancy in the uterus, is the pregnancy viable? How's the gestational age? How does that line up with dating? There's one fourth thing, and you've already presumed it for this pregnancy already.
How many pregnancies are there?
How many embryos? Yes, how many fetuses are in there? Exactly. That's it. Those are the 4 things. If they ask you about this, what's the importance of an early obstetrical ultrasound? Those 4 things. Pregnancy in the uterus or not, is it viable, or can you tell yet how many are in there, and how's our gestational age? That's basically what you can get. Can't really get more. So for chorionicity, when would you be fairly comfortable that you can assess chorionicity if you identify on the 7-week ultrasound that there are 2 fetuses in there?
I'm guessing it's not at this ultrasound. She'd have to come back at a later date.
Not at this one, right? Yes. Yeah, and this is an important thing to know if we've got a multiple pregnancy on the case list.
I'm not sure what gestational age. I guess the best guess would be to have her come back. We usually have them come back in 4 weeks. So perhaps at 12 weeks, you could repeat it, and you'd be looking for any dividing membranes or the lambda sign.
Good, yes. 9 to 10 weeks is usually what the literature would say, and it depends very much on just the capabilities of your sonographers and your ultrasound people in your institution and your community, and it varies. So right, if she was 7 weeks and you brought her back at 11, you would definitely be able to tell by then. Now she, I noticed, also has a BMI of 53. We haven't quite got to that yet, so it may be a little bit later than usual before you can really see what you need to on an OB ultrasound. That's advisable too. Good. So let's say we identify that she has a di twin pregnancy at maybe 11 weeks of gestation. Could you tell us briefly what risks will you now discuss for her for this pregnancy? What are you concerned about as far as risk to both her, aggregate risk to her and to the fetuses during this pregnancy, because she has a twin pregnancy rather than a singleton pregnancy?
So twin pregnancies, kind of in trimester, how I would divide it up in my mind is in the first trimester, she'd be at increased risk for spontaneous miscarriage, possibly hyperemesis gravidarum, owing to, I guess, extra, anyway, I'll stop with that. So.
Oh, no, that's good. Yeah, keep going. That's good.
Hyperemesis. Later on in the pregnancy, there could be fetal growth discrepancies, preterm labor, preterm contractions. During delivery, she'd be at a higher risk for like postpartum hemorrhage, just to name a few.
Yes. Let's see. So you hit early pregnancy. It sounds like we kind of skipped into the third trimester. Anything there in mid-trimester that we should consider?
Mentioned growth discordancies. I guess things like the very obvious things such as potential gestational diabetes, more likely hypertensive disorders, excess weight gain.
Preeclampsia, which she has here also, hypertensive disorder pregnancy. Yes, so that's all true for maternal issues. Is there an increased risk of fetal loss in the second trimester? You mentioned that there is in the first trimester, and you mentioned IUGR and maybe stillbirth in the third trimester.
I think there's an increased risk in all three trimesters.
There is an increased risk in all three trimesters, exactly. Any other risks to the fetuses that we should consider here?
They're at a higher risk for fetal anomalies.
Yes, very good.
Like congenital anomalies, chromosomal abnormalities.
Great.
Yeah.
Absolutely. So with that in mind, how would, just talking about that, how would you recommend screening her for aneuploidies or for congenital anomalies in this pregnancy? What resources or tests would you want to employ here?
Well, what we typically do is offer our patients non-invasive prenatal testing after 10 weeks. And I know that it would be accurate for a twin pregnancy, so I would encourage her to get that.
Okay, sounds good. Anything else?
Well, I know that there's a lot of other aneuploidy screenings that we could do, like a sequential screen and other things like that, which involved, ultrasounds and blood draws.
Yeah.
So if she's at a different practice, we could suggest some of those.
Okay, but you're comfortable with what you have there. So that covers aneuploidies. We also were talking, I think, about congenital anomaly screening. How would you cover that?
Well, it would be something that you would see on an ultrasound, or if an aneuploidy screening indicated that you needed further screening, but more or less signs on an ultrasound.
Good. As far as screening for anomalies, is there any other testing you might do other than your anatomy screening ultrasound, or anything you might recommend to the patient?
Like an MSAFP to check for neural tube defects.
Okay, sure. Would you offer her that?
Depending on her risk factors, we typically go with the the NIPT. But I wouldn't say I don't routinely offer that, I wouldn't say.
Okay. Is there a reason why you don't routinely offer that?
Because we work closely with MFM, and I think that perhaps that's something that they consult patients after they see them during the anatomy, before the anatomy scan. I have to look into that so I have a good answer.
That's okay. It's something that's sort of in the standard recommendations. So yeah, I would know about that. If you offered it to her, okay, this is something I think the examiners might ask about. What's the normal range of AFP for a twin pregnancy?
Oh my goodness, I just read this. I just read that perhaps it's not AFP, but I know that multiples of the median is at 4.5 for twins and 2.5.
There you go. Nailed it. Yep, 0.5. Got it. 0.5 to 2.5 for a singleton pregnancy, 0.5 to 4.5 for a twin pregnancy. You're going to be good on that. It's perfectly okay. Let's see. So she delivered at 33 weeks, and I'm assuming that has something to do with her IUGR and her preeclampsia. if she had no particular issues and her pregnancy progressed just wonderfully, when would you normally consider delivering die-die twins?
With a normal pregnancy, I think it would depend on the positions of the twins. If with die-die twins, if barring any complications, we would maybe discuss per the ARRIVE trial a 39-week induction, or even allow for her to continue to try to go into labor on her own if baby A was cephalic.
Mm-hmm.
But typically 39 weeks.
Are you aware of any particular recommendations at present for when twin gestation should be delivered, gestational ages in weeks?
I believe mono is earlier,
yes,
32 to 34. Mono die maybe 34 to 36.
Yeah, And how about for die-die?
Well, if I was following that logic, it would make sense to say 36 to 38.
Well, 38, they're now saying maybe 38 to 39. 38 has always been the standard for die-die twins. They're kind of pushing up to the last practice will allow that maybe 38 to 39 if everything. Well, I think around the country, I think in the exam, if you were asked, I think 38 would be a very safe thing to say because that's kind of always been the standard. And then you said mode of delivery by how the twins are positioned.
Okay. Correct.
So if fetus A is cephalic and fetus B is breech, in your practice, how would you usually manage mode of delivery in that instance?
Well, I counsel them whether this is first or second, third, fourth pregnancy, and discuss. Say she's a prime, which this patient was. I would say that she certainly would be a candidate for a vaginal delivery, and we would attempt an internal pedalic version during the delivery of twin B with an ultrasound in the OR. But if there were any complications or we were unsuccessful in delivering vaginally, that she'd be at risk of having a C-section, thus having both a vaginal delivery and a C-section. But if that wasn't the case, then she would have a vaginal delivery, which is the goal. I could also talk to her about the fact that she could elect to just have a primary C-section and discuss the risks and benefits of a primary C-section with her as well, encouraging the vaginal delivery trial.
Sounds actually really good. Good. Let's see. We're going to have another minute here. Is there anything you'd like to chat about otherwise about this case, just since we landed on it, or just sort of any questions or anything about what we talked about so far? There are so many ways that we could go, but the examiners are often interested in just sort of hearing how we assess the overall risk of twins, which is just sort of everything in every trimester. It's the increasing risk of all maternal complications. It's obviously always prematurity, loss in all 3 trimesters. Then you get into the growth discordances and the IUGR, right? The increased risk of just sort of anything that could happen for a singleton pregnancy, the anomalies, the aneuploidies, delivery complications, all of that. Cool.
Yeah, this one I know pretty well, at least the person in the case, but I can't think of anything specifically. But thank you for going over it.
No, that's good. Thank you. That was actually a good one to review. Also, thank you very much. Let's go to Ebony now, since I'm unmuting her. Let me get back to case list here for just a moment. Let's see, Ebony, trying to unmute here for a minute. Still working. Oh, there you go, Ebony. Hey, Ebony, can you hear us okay?
Yes, how are you guys doing?
Oh, hi. Hey, thanks for joining us again. All right, have your case list up here. Anything particular you'd like to talk about?
Not at this time.
Okay. Let's see, could we go to something maybe GYN or office, since we've done some OB already? Sure. Great. Let's go maybe move up to GYN. We'll get some office before we finish the hour. Let's see. Is there anything on your GYN cases you've been looking over in the past several days or so that now that we're on GYN, that you'd like us to talk about, or otherwise we'll just pick something here.
We can pick random. I've been looking at more open stuff.
Sounds good. Let's see. Let's see what we got here. Let's see. Let's go back to here. I had a couple good ones up here. Let's see. We look at case number 15 under operative management pelvic pain. 27-year-old, gravida 3, para 3. Pelvic pain, dyspareunia, failed medical management. A lot of end and ablation, a lot of stuff going on here, and she ended up getting a TLH and a cystoscopy. Good. with this patient, pelvic pain is a very broad category. And when we use the term pelvic pain on the cases, the examiners can go anywhere with it. So one useful place to start would be just to start this patient at the very beginning. If you were working her up, and she came in at 27, referred from maybe her primary doctor, just because they weren't really comfortable managing the idea. She was reporting pelvic pain and pain with intercourse, and I take it this has been going on for a while.
Yeah.
What would be the important components of your work as far as specifically trying to identify whether this pain might be gynecologic in origin rather than something non-gynecologic? How would you focus yourself in working this patient up?
Well, I would start by trying to evaluate whether or not it was a non-GYN cause first, just to see if there was something else that I could do for her. So rule out infection, rule out urinary tract infection or vaginal infection. I would also try to get a good history regarding her bleeding history and whether or not the patient was still having menses even after having an ablation. I would try to determine whether or not her pain was cyclic, her pelvic pain, and whether it aligned with when her menses typically, if she wasn't getting her period, then if it aligned with when she typically would have, or if she still was getting her menses, then if that pain was associated with that. I would then try to evaluate further her pain with intercourse and whether it was all the time or was it positional or with, during a certain, if it was on her menses or if her bladder or her bowel were full at that time as well, just to kind of get a good idea of when she was experiencing the pain and then also what she's done in the past to alleviate the pain.
Okay. Anything else you might want to ask her that might help you sort of to get into the gynecologic versus non-gynecologic issue here? What you've said so far is actually, I think, a really nice, strong start.
What other things I would do a part of my evaluation? I would do definitely.
Well, just think about history. Anything else that you might want to ask her about that might sort of help to hone in on this gynecologic versus non-gynecologic, and sort of ruling in and ruling out things.
I would evaluate her surgical history further and seeing that she's had 3 prior children. Was that vaginal or cesarean? Looking at her history, she's had a history of cervical dysplasia as well as a salpingectomy and an ablation. And so seeing if I could even get a copy of her op note to see if she's had any prior adhesions or any indication for that being a cause of her pain. And then I would do a thorough GI and GU history to see if she was complaining of any constipation or diarrhea.
Okay. How about on your physical exam? Given what she is presenting with, what specific things would you be testing or looking for on a physical exam here?
Well, I would start, from head to toe, and I would look to specifically to see if she had any abdominal pain with my physical exam initially, to see if with palpation of her abdomen, I could elicit the pain that she was feeling. And then I would do a vaginal exam to see if there was any sort of anatomical changes or cause for possibly her pain with intercourse.
What particularly are you looking for there?
I would look on my pelvic exam to see if her cervix was large or felt like there was a polyp or possibly even a fibroid prolapsing through her cervix. I would look to see if there was fullness in her posterior vaginal area to see if there was any sort of mass internally as well, or if there was any mobility of her uterus, or if I felt like it was larger and a possibly cause of her pain. Depending on her prior surgical history, I would try to see if I could feel any sort of scar tissue on her abdomen and also internally as well. If she had she had a prior leap, so that could also be causing her pain, any scar tissue on her cervix.
Okay. In this woman, then, given that she has gynecologic pelvic pain and dyspareunia, those two, and she's 27 years old and she's been pregnant 3 times, what would be a basic differential diagnosis as you'd be thinking of as to what might be causing her pain? How would you start to put your list together so you could start to work her up a bit?
Regarding GYN pain, I would start with her surgical history with prior cesarean deliveries, as well as abdominal surgery with her salpingectomy, being caused by adhesions. I would also consider a post-ablation tubal syndrome as well. I would consider get a better history regarding her prior menses and why she had an ablation, possibly consider her having endometriosis as well. And then, of course, if there's fibroids, that would add on my differential as well.
If you were working her up sort of from scratch, at what point would you consider a laparoscopy as part of your evaluation?
Depending on her menstrual history and whether or not this pain was cyclic or not, I would consider starting her on medical management first, whether that was continuous OCPs or even possibly a GnRH antagonist to see if possibly that would cause her pain to be relieved. Depending on how the patient responded to that medication, then I would consider doing a laparoscopy.
Sounds good. So if you decide to give her 3 months of Leuprolide and her symptoms actually significantly improved on Leuprolide, what would you have learned from that? How would that guide your future management?
It would have lended me obviously more towards a GYN cause of her pain and likely due to endometriosis and or even post-ablation tubal syndrome could also be quieted down by Lupron.
Really? How would that work?
Well, for specifically with post-ablation tubal syndrome, there's the theory behind it is that there's still active endometrial tissue and the patient is still, instead of having an active period, they are having bleeding into the stumps of the cornua of their and so that can still cause pain, but with the Lupron, it could stop the cycle of her endometrium.
Right. Agreed. So anything aside from endometriosis or post-ablation tubal syndrome that might be on your differential diagnosis if her symptoms got better with Leuprolide?
It could also be just cyclic ovulation pain, although it probably wouldn't have caused the dyspareunia, but he was feeling cyclic pain. It could have been cyst formation on her ovaries and or middle switch. And so the Lupron would quiet that down as well.
Good. Anything else when we're thinking about gynecologic things where Lupron might actually help?
It could help with a fibroid as well.
True, degenerating myomata, I think that's possible. Initially, it might aggravate them, but it would come. Not sure. Anything else along it here? We're doing well. At the top of your list, you mentioned a concern for pelvic adhesions, particularly around the adnexa. Would those likely be improved or possibly be improved by 3 months of Leuprolide?
Not to my understanding. I have not used Lupron for management of adhesions, but possibly.
Well, I agree. I don't think we'd use them for management of adhesions, but is that one of the things that could be tamed a bit maybe by Lupron or maybe not?
I don't think so, but it's possible.
Well, we have to think about why it is that adnexal adhesions would cause pain. I mean, just the scar tissue itself does not have any nerve tissue in it, right? It's fibrous tissue. So what is it about the adhesions, though, that causes pain in the adnexa, given that the adhesions themselves are not innervated?
I guess it would cause torsion, or if the ovaries are enlarged, then that can cause some sort of.
Right, the ovaries do cycle, and they enlarge, they engorge. There's actually ovulation activity. There's stretch that goes on in here, and if there's adhesions in there, the capsule of the ovary can be sensitive. That yes, so in that instance, might Leuprolide actually cause some improvement in the symptoms?
Yeah, absolutely.
Yeah, what? Yeah, adenomyosis, would that be improved by Leuprolide?
Yes.
Yes. Pelvic varicosities or pelvic venous congestion syndrome, might that be improved by Leuprolide?
Yep.
Yes, all of the above. Yes, so we got a good long list here. Good. So if her symptoms got significantly better on Lupron, you said maybe then you would do a laparoscopy?
If they didn't get better, I would think. If they got better with Leuprolide and she didn't want to continue on the medication.
Right. Yeah. Well, you can use Leuprolide only for so long. That's true.
Yeah. Then I would consider doing a diagnostic lab to see if there was any other physical.
Good. it could provide a diagnosis for which you would then be able to target your medical therapy. That's true. It could be any of the things that we, I think, just mentioned. Sure. Mm-hmm. So if her symptoms did not at all improve on 3 months of leucolide, how would you proceed then?
Well, I would hope that I've already evaluated and ruled out any other cause, GI or GU source.
Sure.
I would, typically I offer patients physical therapy as well prior to surgery. So I would offer that again if the patient declined. And then I would dig a little bit deeper into what, the dyspareunia, and then consider even other causes of her pain, whether it's physical or mental pain as well.
Good, very good. If there's no change on 3 months of lupron, we have to be very suspicious that this is not primary gynecologic pain, and then we recruit other people to help us. And then I think not a laparoscopy right away, because now we're looking other places, and doing an invasive surgical procedure could actually aggravate the pain, especially if you don't know what it is.
Right.
I think that's a very astute answer there. Good. We covered a lot of ground there, Ebony. Is there anything about that you'd like to talk about, or just kind of questions or anything we should go over? That was sort of where the examiners can go as far as kind of the basic sort of cone down approach to pelvic pain, I think.
Okay. No, I think for her, she was on, I believe, Orlissa, and did, like, her pain got better, but she didn't like the symptoms.
Sure.
So that, failed management. I guess it can perceive as though it didn't work for her pain. I didn't really say that differently.
Well, she had failed management. She also had failed surgical management with an ablation. So she was kind of heading toward and you worried about the tubal ablation. She's headed toward a hysterectomy, I'm quite certain.
Yeah.
Good.
I have a couple
discussion. Yes, go ahead.
I have a couple of these on my list, like younger than 40, that I'm sure they're going to, hone in on. A lot of them have had surgeries before, whether it's deliveries or ablations, and it was kind of,
No, so it's good to talk about this, because this is right. Examiners do pay attention to the stuff in the exam. Good, Ebony, nicely done. Thank you for taking that on with us. Thanks. We are good. Anyone who would like to raise your hand, please. We haven't heard from Dr. Pham or Dr. Herzog yet, and would love to go over a case with either one of you too, if you'd like to just click the raise it there. Dr. Pham, thanks. Let me just get out of case list there. We'll come to you in just a second. Tiffany, thanks. There we go. Hey, Tiffany, thanks for joining us this evening. Let me bring your case list up. Let's see. Oh, that's right. I remember we just have your OB in your office case list. I'll talk about anything GYN that you want to. Is there anything particular you would like to look at or chat about this evening while we have a little time?
Anything is fine.
Okay. Could we do office, because we haven't hit it yet this evening? Okay, we'll do office. We'll find something over there. While we're going down to office, anything just on office particularly that would be interesting for you to talk about?
Anything is fine.
Good. Let's see. Can we talk about case number 8, a well-member visit planning for pregnancy? So this could actually be kind of a preconception visit. This is a 34-year-old, it looks like, who's never been pregnant, and it looks like she's actually very healthy. If she is now talking about maybe in the next 6 months or so, she'd actually start attempting for her first pregnancy. What would you feel if you had to make a list of maybe the 5 or 6 most important things that you'd want to address with her as far as preparing for and optimizing for conceiving a pregnancy healthily? What would you chat with her about? What would you recommend?
I would advise her to take prenatal vitamins and make sure that it's got at least 400 to 800 micrograms of folic acid to prevent neural tube defects. And she's pretty healthy, but making sure that she's maintaining a healthy diet that's well balanced, exercising at least 30 minutes a day, 5 days a week, avoidance of tobacco, alcohol, any illicit drug use, and kind of along those lines, talking about any environmental or work related toxic exposure type of things. And then what else? Along with, I guess, kind of in this pandemic, if she has not already been vaccinated for the COVID vaccine, I would advise her that, it's safe in pregnancy and while breastfeeding, And when the flu season comes around, she should also be up to date on the flu vaccine.
Good.
And then I think those would be like the big things, but in terms of like optimizing her health. But I would also touch base on whether or not she's immune to rubella and chickenpox. And if she is not, we can check for, or like if she's unsure, we can check her titers. And this is something that she can be vaccinated for before she gets pregnant, because it contains live virus and we would not give it during pregnancy. Okay. And lastly, I would talk to her about carrier screening and give her the option of doing that now.
Oh, tell me about that. What particular types of carrier screening would you want to talk with her about at age 34?
So for carrier screening, the kind of core panel would include testing for cystic fibrosis, spinal muscular atrophy, and Fragile X, and this is for all patients. However, if she is of a higher risk group, such as African descent, we might be concerned about sickle cell, South Asian descent, Mediterranean, Middle Eastern. I would be concerned about thalassemia. If she is of Ashkenazi Jew descent, then she would be someone I would recommend doing comprehensive carrier screening to catch all those, to check for those rare conditions that are rare in the general population, but more common in Ashkenazi Jew population.
Sounds good. That was a nice run through on that. Just so while we're talking about carrier screening, then, if she actually does have a European or Russian Jewish ancestry history on both sides of her family, you said you would do an ashkenazi panel with her. If you did so, and the only thing that turned up actually is that she was positive as a carrier for Tay-Sachs disease, how would you counsel her about that? What would be your next recommended step in evaluation in this case?
My recommendation would be that her partner should also be tested because this disease is inherited in an autosomal recessive fashion manner. So if she is a carrier, but her partner is not, there's no chance that her baby may have the condition. However, if both her and her partner are carriers, there's a 25% chance that the baby may actually have the condition. And then I typically offer, if it's kind of up to her whether she would like to proceed with genetic counseling at this time to get some more information, or whether she would like to wait for the results for her partner to come back first.
Sounds good. If her partner also tests positive for Tay-Sachs as a carrier, what would you recommend now?
Genetic counseling, so that she can learn more about Tay-Sachs and kind of get more information about her risk of her baby having the condition.
Good. If she asked you, would you be able to tell her at this point anything just very basic about sort of what Tay-Sachs represents?
This is something that I would have to go back look at, but I believe it involves like metabolic issues for the.
That's a perfectly satisfactory answer. You really do. If you had a patient with Tay-Sachs on your case list, you need to know more about it. Going up and looking at it would be that's perfectly fine. You're right. It's hexosaminidose A is the deficiency enzyme. So it actually has to do with mucopolysaccharide metabolism. And life expectancy is shortened with Tay-Sachs. It's young adulthood, maybe mid-adulthood at best. But that's really, at this point, we're so far into the exam that you can just at any point say, I don't know, and that is perfectly okay, and the examiner will go on to anything else, because really you reported all the really important stuff about that. You got at the important things that we want to think about in a healthy woman as far as planning for pregnancy. Now, you did very briefly mention the COVID vaccine for you. If you discover that as of today she has not yet been COVID immunized, what would you recommend anything particular as far as vaccination right now?
I would recommend that she get vaccinated because as far as in terms of, well, she's not pregnant at the moment. However, she's considered immunocompromised if she does get pregnant. And she could end up in the hospital and needing a ventilator in the ICU. We don't know the effects of COVID on the pregnancy and the risk of like stillbirth or preterm delivery, So kind of for all those reasons and the increased prevalence of cases currently, I would recommend get vaccinated.
Good. Just to interject, actually, we do know that with pregnant women with serious disease, COVID, there is an increased risk in adverse outcomes, including neonatal demise, stillbirth, and definitely prematurity. With mild to moderate maternal disease, that does not seem to be the case. We do know that for severe disease. So would you recommend any particular COVID vaccine for her?
Because there has been some concern for blood clots associated, although rare, with the Johnson & Johnson vaccine, I would recommend that she get the Moderna or Pfizer vaccine.
Good. If there was no Moderna or Pfizer in her community, there was only J&J, what would you recommend to her?
I would recommend that she should still get vaccinated because the risk, the incidence of blood clots is still.
Yes, yeah. The most recent advisory, which was out July 2nd on the ACOG website, and which is only about 6 weeks old, once again made the point that pregnant women should get vaccinated immediately. Anyone contemplating pregnancy should do so immediately. Any vaccine is considered safe. The risk of the TTS, the thrombotic thrombocytopenia syndrome, is extraordinarily rare. It's like 1 in every 9 million injections with this vaccine. But still, you're right. If Moderna or Pfizer is available, that would be great. But all vaccines are considered safe and should be recommended. That was exactly the right answer to give. Good. Let's see. Tiffany, anything else you'd like to discuss here? This has been very nice so far.
No.
This is pretty much how the exam goes. We started out very superficially with a broad view of just sort of preconception screening. We decided to tunnel into Tay-Sachs for a little bit, and then they'll jump off and they'll go do something completely different. And that's kind of how the exam goes. So no, I thought you handled that very nicely. Thank you. That was great.
Awesome.
Thank you. We still have maybe about 10 minutes left. If Dr. Herzlich would like to do anything, please raise your hand and I'll go. Thank you. There you go. You just unmute you and I'm going to go back to your case list here for just a moment. See if I can unmute you again. I'm trying to see if I can get you unmuted there. Ah, there we go. Gotcha. Hey, thanks. Hey, let me just run down and get your case list here for a moment right here. Thanks. Anything in particular, since I have your entire case list here, anything particular you'd like to look at this evening?
Maybe we can jump to OB. I don't have anything in particular there.
So just anything at all in OB. Okay, let's do that. Sounds good. Let's see. Can we look at maybe case number 4? This is actually, it looks like cervical insufficiency and some PROM going on at 29 weeks or so. Looks like you got a nice outcome though. So you have a diagnosis here of short cervix in this 26-year-old. In general, what is your screening for cervical length in an uncomplicated pregnancy? Now she's a gravid 7 para-0, but this looks like her first pregnancy where she's actually made it well into viability.
Right. For just as a comment for this specific patient, she had elective termination, so it's not that she had miscarriages or anything like that.
Good.
But in terms of screening for short cervix,
what's the current recommendation for that for just healthy women in pregnancy?
So the current recommendation will be to do a screening. It's going to be universal between 18 weeks to 22. Usually will be done together with the anatomy, with the level 2. For low risk patients, we can do transabdominal, and if the cervical length is more, for 3.6, then it should be considered as not at risk for cervical insufficiency. And if it's anything below that, the recommendation is to do a transvaginal.
Okay. If on this routine 18 to 20, let's say 20-week anatomy survey, her cervix was measuring 2 centimeters long and closed, how would you counsel her about that? And what might be your next step in evaluating and managing this finding?
So 2 centimeters is considered short cervix. So I would counsel her that for any person with a cervical length below 25 millimeters, there's a higher risk for preterm delivery. and the complications of prematurity that come along with that. And I would recommend her to go on vaginal progesterone.
Good. What vaginal progesterone do you use in your practice for that?
I usually do not prescribe it myself, and I co-manage it with an MFM.
If you were to be doing it yourself, what do you have an idea of what's commonly used?
No,
that's okay. And if you need to look it up, that's okay. You can say I don't know at that point. And I'm sorry, you were going to say something.
Yeah, the 17-hydroxyprogesterone is the IM one.
That's the IM, yes.
Vaginal, I'm not sure.
Yeah, vaginal it's prometrium. It's actually vaginal progesterone. It's usually 200 milligrams just once a day vaginally is kind of the standard dose. Since you brought it up, would she be a candidate now for the 17-hydroxyprogesterone injections weekly? Because she's under 24 weeks and she does have a short cervix. And as you mentioned, she's at risk of prematurity. Would you categorize this case as cervical insufficiency at this point?
I think to define cervical insufficiency, yeah, we can say that a short cervix.
Less than 25 millimeters or 2.5 centimeters, you can absolutely do that. Yeah. So would you consider 17-hydroxyprogesterone injections for her weekly at this point?
So in regards to that, the new data shows that the recommendation for 17-hydroxyprogesterone will be only for people with history of preterm delivery, without short cervix. And even for that, data is more supportive of benefits from the vaginal progesterone. So for her specifically, I would not suggest to go for the IM for this.
That sounds exactly right. But vaginal progesterone, yes. So we said she's 20 weeks and she has a short cervix of 2 centimeters. When would you next check her cervical length then?
So I would do serial examinations for cervical length, and that will depends on the length, between 1 to 4 weeks apart until she's 24 weeks. To see if we recommend for any cerclage.
Sure. No, that's the textbook. That's right there. For this, let's say for this patient in your practice, given that all out of the blue you discovered the short cervix 2 centimeters at 20 weeks, how often would you be checking her cervical length? Because every 1 to 4 weeks is a pretty wide range. What would you actually do?
So I will start with every week, and if I see that it's stable, depends when we start, of course.
Yeah.
But if I see that it's stable, then I will space it out a little more.
Good. That sounds good. Now, you mentioned cerclage. Under what circumstances would you consider a cerclage for this patient?
So I would recommend her cerclage for a very short cervix, and that would be less than 10 millimeters, or of course, if there's an examination that shows cervical dilation.
That's good. If your next ultrasound a week actually showed that the cervix was 10 millimeters and 1 centimeter dilated through to the internal os, what would you do at that point?
So in my practice, I would counsel, I would get an MFM consult, but in general, what I would tell the patient that she's a higher risk for preterm delivery. The things that we can do to avoid that will be a cerclage, and we may put that if she has no other contraindications for that, and we'll have to assess whether she has any infection going on. If she's in labor, of course, we would not do that. Or if there's anything that would consider the pregnancy as not beneficial to to be prolonged, such as anencephaly or any other fetal anomaly that would not gain anything from just prolonging the pregnancy.
Good. Let's see, I think maybe last question. If we're considering cerclage, how would you discuss with her the risks and benefits of having a rescue cerclage? Because that's what this would be at 21 weeks of pregnancy for a dilated cervix.
So in terms of the risk of the procedure itself, so first of all, with any procedure, we have risk infection and bleeding. There is also risk, and that is specifically for cases when the membranes are bulging, for rupturing the membranes accidentally, and then the patient can go into preterm labor. I mean, rupture of membranes and preterm labor. And then I would tell her that even in a successful procedure, there's still cases that would not benefit from just the fact that the cerclage is there, and then they can still progress into preterm labor.
That's right. Very good. Very good. So we're talking about cervical insufficiency here. So it seems like, I believe we ruled out preterm labor as the underlying cause, but preterm labor is still a very high risk for her. That's right. So PROM, preterm labor, right? Failure of the cerclage due to either.
Yes, and then in terms of alternatives, is not. I mean, continuing with just taking the vaginal progesterone is an option. And in that case, she knows that she's already in a risk for preterm delivery.
Yes. Sounds good. Very last question. I don't know. I said the last one would be the last one. If you were doing the cerclage, would you give her prophylactic antibiotics for placement of the cerclage?
It's not indicated.
It's not. You're right.
What I do in my practice, this is also not necessity. It's not indicated, but I do give indocin around the procedure because sometimes the manipulation will cause some crampings and contractions. So I would like to avoid that, and I will give indocin at the day or 48 hours around the procedure.
So do you mean starting before or starting after the procedure?
I would start right before and go
right before. Good.
48 Perfect. Hours.
That sounds great. Good. That was a nice run through short cervix. That was you did that really nicely. I think you covered all the bases. There's nothing in there that would have been anything less than a really solid pass on that question. And for all of our candidates, again, we were discussing this amongst ourselves and faculty this past week at our second Baltimore course. Just really good native oral examination skills in our candidates this year. All 5 of you this evening have done a really nice job. We've had good discussions, just good focused answers, structured approaches to managing patients, good clinical knowledge, so you know patients, you know patient management. These are things that are really helpful when you're starting to learn how to manage an oral examination, and you've all done really nicely with that this evening. Aviv, we will need to close down in a minute. Anything you'd like to ask about or talk about on this case before we finish for the evening?
No, I think we covered pretty much.
We did a lot. Yes, and you actually did most of it. Yes, that was very nice. Thank you for doing that. Good. Thank you to all of our candidates. That was actually a great session this evening. Tomorrow, one of our faculty will be back, and we are doing structured cases, I believe, again at 8:30 Eastern. And I would look forward to catching up with you, I think, in just about a week's time. Do remember, these are all archived on the Examper website. You may go and re-listen to them and check out any ones that you've missed at any time. Thanks, everybody, for attending. We will stop for the evening. Have a very pleasant rest of the evening, everybody. Thanks.